Okay. So what is the provisional diagnosis? The next question. So provisional diagnosis, a 35 years old woman with post-burn contracture of neck with one finger mouth opening, posted for contracture release. So in next question which could be asked, what do we expect in the for our anesthetic concern in these patients? So patient coming with burn contracture, what is important anesthetic concern? Definitely, one we have during evaluation seen that there is a airway difficulty anticipated. So difficult airway. The other problems which we can face is the neuromuscular blocker effect. The use of muscle relaxant during the procedure. We need to know post-burn, the metabolism, the effect of neuromuscular blockers, both depolarizing and non-depolarizing changes. So we need to be aware of that fact. So use of muscle relaxant. Then patient positioning may be difficult and it's of important concern in these patients. Then IV access would be difficult because of the scar developed due to burn. Application of monitor may be difficult in these patients because of the skin changes in chest and all. Applications of monitor, we may need to change the place where we have to put the monitor. And there is always a risk of hypothermia in acute burn injury, post-acute burn injury, because of large surface area exposed and the heat loss by evaporation very high. If post-acute burn injury, we give patient anesthesia because of the disturbance of the thermoregulatory system and increased skin exposure, risk of hypothermia is very high. Also, in burn patient, there's a reset of thermoregulatory center. So these are the important anesthetic concerns for us in a post-burn or a burn patient, right? So let us come back on our patient. What are the options available after examining? So airway concern is our main concern. So what are the options available for airway management in this patient? What would be the gold standard? What are the other options if we cannot go for gold standard? So the gold standard is awake nasal fiber optic intubation. Oral is really difficult in this patient because of one finger breath mouth opening. Nasal would be better. So nasal awake fiber optic intubation. That would be the gold standard. Gold standard. So my patient has one finger breath mouth opening. So I have very limited options. This would be my best option, and other options could be there in the patient who has a post-burn contracture but little more mouth opening. So if a patient has a two-finger breath mouth opening, then intubating LMA with endotracheal intubation is possible with the use of intubating LMA. LMA classic we can use if we are expecting, if patient has more than two-finger breath mouth opening and if we are expecting that patient has a tracheal stenosis. Pre-induction release of contracture with the help of local anesthetic and ketamine, and then we intubate the patient for the further surgery once the contracture is released. To some extent, the airway will become easy. So pre-induction neck contracture release under LA plus ketamine. Tumescent anesthesia we practice. Then elective tracheostomy if we suspect that nasal fiber optic would also be very difficult, and we need to plan about elective tracheostomy. So these are the options available for our patient post-burn contracture. So the gold standard is awake nasal fiber optic intubation. The question would shift towards how do we do the awake nasal fiber optic intubation. So the next question could be, so how would you prepare a patient for awake fiber optic? There should always be a checklist which should be followed so we do not miss any important thing. Airway is difficult, so the checklist should be properly followed. In the checklist, everything should be ticked that we have done all these things so that we do not face problem when we are doing the procedure. So material and equipments required for the securement of airway should be checked. So prior to the beginning of procedure, we should confirm that equipment for anesthetizing air and managing difficult airway and visualizing the airway are readily available and operational. So every device should be readily available and operational. So our difficult airway cart should be available with all the device operational and checked. Then ergonomics should be very, very clear. What do I mean by ergonomics? When we are practicing fiber optic, we have to see the monitor, right? We have to see the screen of the fiber optic when we are inserting it. So it should be proper line of sight, so we don't have to flex our neck. That would affect our procedure. So operators line of sight should align with airway management device, the fiber optic scope, patient and device screen. So it should be a proper alignment, whether you are doing it while facing the patient's face or doing from the head end of the patient. So your devices should be aligned in a proper way to prevent any operational difficulty during the procedure. Then the screen of monitor with the monitors attached should be visible. Supplemental oxygen delivering device and suctions should be working. Ensure that anesthesia machine and ventilator is available and is operational. It should be checked. And any airway management equipment, which is the part of our rescue plan, should be arranged properly. Okay. So this is how we do the preparation. So this is the site preparation. Now, how do you prepare the patient? The next question is, how should the patient preparation be done? So, for Awake nasal fiber optic, what preparation we need to be do in the patient? So, there are few important drugs and few important local application that we have to practice. Few blocks which we can practice in these patients. So, patient first thing, whenever you are going for awake endotracheal intubation by fiber optic or video laryngoscope, any device, you need to properly communicate it with the patient. So proper communication with the patient is of prime importance. Then you need to dry the airway of the patient, because the release of secretions in the oral cavity would make the visibility very difficult, right? Would we make the visibility very difficult? Plus, it will also make the effect of local anesthetic less, right? So, glycopyrrolate prior to minimizing the secretions. We should always give our patient glycopyrrolate, IV or IM, depending upon how much time we have prior to doing the procedure. So, small amount of secretion can also impair the visualization by the fiber optic or by video laryngoscope if you are using video laryngoscope. Secretions can also decrease the efficacy of the topical local anesthetic which we have applied. So, patient cooperation may not be that good if our let's say secretions are there. Glycopyrrolate, the dose 0.2 milligram IV, 0.2 milligram IV 15 to 30 minutes before procedure if the time permits. So 15 to 30 minutes prior to procedure we have to give. The other thing, we have to prepare the nose of the patient for the procedure. See, nasal cavity is very vascular. If a bleeding happens during nasal fiber optic endoscopy, the issue would be that visibility would be gone and it will be very difficult with a reduced mouth opening to manage the patient's airway. So, we give nasal vasoconstrictor. So, prior to awake nasal intubation, we use topical vasoconstrictor, oxymetazoline or phenylephrine. Both are commercially available. Oxymetazoline is considered as a better one. It is considered as a better one and it reduces the risk of bleeding and it also enlarges the caliber of the nasal passage. So, the commercially available oxymetazoline, the concentration is 0.05%. We twice apply it before the procedure. At the same time, we are giving the glycopyrrolate. Once at the same time, we are giving the glycopyrrolate and once just 10 minutes before the procedure. Phenylephrine 0.5% is available. So 0.05% oxymetazoline and 0.5% phenylephrine. Oxymetazoline is considered a better one. Then if a patient is a high risk for aspiration, we should give anti-aspiration prophylaxis, right? Because there is a possibility for a let's say if we sedate the patient a little bit during the procedure, patient can aspirate. So in high risk patient for aspiration, anti-aspiration prophylaxis should be given. Now, What monitors should be attached during the procedure? Now, all basic ASA monitors. So, what monitors should be the next question? So, for monitoring, we should attach all the ASA standard monitor. ASA standard monitor. So, what are the ASA standard monitors? ECG, pulse oximetry, then your non-invasive blood pressure monitoring, and during the procedure, if possible, capnography also. Let's say there are a lot of ways by which we can put capnography through the oxygen delivering device. We can attach the capnography and we can see the reading. And after the procedure, definitely capnography should be available for the confirmation of the airway device. So, pulse oximetry, blood pressure monitoring, cardiac monitoring, the ECG, and ETCO2, right? Here, one very important thing which the examiner can ask: do you do any more before starting the procedure? Yes. According to the body weight of the patient, we calculate the maximum safest dose of local anesthetic which we can use in the patient, because we are using local anesthetic for topical application or nerve block. Number of times we overdo it and we give a lot of doses of local anesthetic, and that could result in last local anesthetic systemic toxicity. So we have to be very careful. We have to calculate the overall highest safe dose. And one thing we need to keep in mind, that the most common local anesthetic which we are using, as the examiner can ask you, is your lignocaine, that is your xylocard or xylocaine you're using. So when you are using xylocaine, the most common local anesthetic, the maximum safest dose of xylocard when using for airway anesthetization topically or by nerve block, the overall safe dose has increased, right? Because absorption compared to by other way is less. So overall safe dose is little more. So little more than the overall safe dose we can give. But definitely we need to calculate the safest dose, and it should be in our mind that according to the body weight of this patient, 350 milligram of xylocard or xylocaine is safe in this patient. Got my point? Xylocaine is safe in this patient. Okay. Then, during the procedure, always a continuous oxygen supply should be added. If we are going for oral fiber optic, then we can go for HFNC through nose. We can attach high flow nasal cannula at a flow of 15 to 60 liter, whatever we want, through the nasal cannula continuously. That would be the best device because it is giving us humidified oxygen. Or we can simply attach conventional nasal cannula. If we are going through for nasal fiber optic, nasal passage, through nasal passage we are going for fiber optic, then in that case, we can apply the conventional nasal cannula, and before inserting the fiber optic device, we just remove from the cannula from one of the nares. The other nares, the cannula would still be there in the place. From one of the nares, we can remove it. Okay. So for patient undergoing oral route for the fiber optic intubation, the HFNC, high flow nasal oxygen, typically at the flow 15 to 70 liter per minute, we can use. Standard nasal cannula at a flow of 15 liter per minute can be also used as a good alternative. Okay. Patient undergoing nasotracheal, we go for standard nasal cannula with nasal prong removed from one of the nares during the procedure. Okay. But try for a continuous oxygen supplementers. This will give you more time. This will increase your time, right? It will decrease the risk in the patient of hypoxia. Okay. So what are the techniques of airway anesthesia? How do we anesthetize the airway during awake fiber optic? There are two ways: by topical application of the local anesthetic or by performing some airway blocks. So we can go for topical application, we can go for performing some airway blocks. Both can be done in combination, or one of it can be practiced. So we can choose from topical anesthesia or nerve block, or we can go for combination as well. We can go for combination, right? So first I will discuss with you how do we anesthetize the airway topically. So topical anesthesia. So when we are doing awake fiber optic, we have to anesthetize, right, the entire path our device will pass. So for oral, the oropharynx, the larynx, the trachea has to be anesthetized. And for nasal route, we have to anesthetize the nasal cavity as well, and definitely the oropharynx, the hypopharynx, the larynx, and the trachea. So, for oropharynx and larynx anesthetization, topical local anesthetic should be applied to the base of tongue, oropharynx, hypopharynx, and laryngeal structure. So, these structure has to be anesthetized. The most common drug which we use is lidocaine, because it has a rapid onset. First point, high therapeutic index, safety margin is more than what we calculate through by other, when we give it the lidocaine by other routes of regional anesthesia. We can give little more because absorption is less, right? So we can give, the safety margin is even better. Then availability is also easy for lidocaine. It is available at most of the places, right? And it is available in wide variety of concentration and preparation. Ointments are available, sprays are available, creams are available, so we can use it, right? So lidocaine is most common one which we are using. Okay. Now, what is the best way, topical way of anesthetizing the entire airway? Well, that would be nebulization with 4% lidocaine. So, nebulization with 4% lidocaine with oxygen flow at the rate 2 to 4 liter per minute to generate the larger particles of the lidocaine. So, it will deposit in oropharynx and upper airway, right? It provides a very good, let's say, very good anesthetization of the entire airway. Okay. So, initially we start with oxygen flow rate 2 to 4 liter per minute. Then gradually we increase the oxygen flow rate during nebulization to make the, to generate a smaller particle which will flow to the lower airways. So, entire upper to lower airway would be anesthetized. The volume of 4% lidocaine, we can use 5 ml 4% lidocaine in any patient more than 40 kg weight. So, more than 40 kg weight, we can use 5 ml 4% lidocaine. You know, only 30% of this is absorbed. 4% 5 ml means 40 into 5, that would be 200 milligram of lidocaine we are giving. But of this, only 30% would be absorbed. So, it is not that this entire would get absorbed, only 30% would be absorbed. So, the margin of safety is higher. Remember this is the best way for topical anesthetization through of the airway through local anesthetic. Nebulization, easy. When should we do the nebulization? 45 minutes prior to the procedure, 30 to 45 minutes prior to the procedure. So, it should be done 30 to 45 minutes prior to the procedure for the optimal effect. Okay. Now, if I am going for nasal fiber optic, as in my case, I would go for nasal fiber optic. Then, as I said, the nasal passages should also be anesthetized. By nebulization, it can be done, or we can do it with some topical application of local anesthetic. So, after administering the topical vasoconstrictor, during the preparation of the patient, we give the topical vasoconstrictor. After application of this, we can apply the local anesthetic. Now, we can use bilaterally in the nasopharyngeal airway, we can give 2% mucosal jelly, like lignocaine mucosal jelly. It will facilitate the passing of the fibroscope, and also it would anesthetize the nasal cavity. So, instead of water-based jelly, for facilitation of the introduction of the fibroscope, use the lidocaine 2% mucosal jelly or 5% lidocaine ointment. So, number of times examiner asks the concentration. So, mucosal jelly is available in 2% and the ointment 5%. It would lubricate the passage and it will also anesthetize the passage. Alternatively, what we can do? We can give the combination of local anesthetic and vasoconstrictor together. There are a lot of combinations which has been described. So, examiner can ask what combination, we can practice for the let's say vasoconstriction and anesthetizing the airway. So, the options are lidocaine 2 to 4% with epinephrine. Epinephrine would vasoconstrict, lidocaine would anesthetize. 3:1 mixture of 4% lidocaine and 1% phenylepinephrine, and 1:1 mixture of 4% lidocaine and 0.05% oxybetazoline. So, what we can do? we can directly apply the combination of local anesthetic and vasoconstrictor in a cotton pledget. The solution would be soaked in a cotton pledgets, and we could just pack the nose with that pledgets, and we leave it for 3 to 5 minutes. So both anesthetization and vasoconstriction would be achieved. So this is how we anesthetize the nasal passage. Okay. So what are the blocks for anesthetizing the airway? What are the airway blocks? So there are few very important blocks we need to practice, right from anesthetizing the nasal cavity to the upper airway to the trachea, right? So what are the different blocks? So the important blocks which we can use, see, for depending upon how you are approaching the procedure. If we are doing awake video laryngoscopy, then for awake video laryngoscopy, we will introduce the video laryngoscope from the oral cavity. So definitely the gag reflexes are very strong when you introduce any device from oral cavity in a awake patient. So you need to block the nerves which are responsible for gag reflex, and glossopharyngeal nerve is the important limb of gag reflex, the efferent limb of gag reflex. So we have to block the glossopharyngeal nerve. So for patient with prominent gag reflex, we have to block the glossopharyngeal nerve, right? This will provide anesthesia for posterior third of the tongue, and it will block the afferent limb of the gag reflex. For nasal approach, we should anesthetize the nasal cavity through two important blocks, sphenopalatine block and anterior ethmoidal block. So, a sphenopalatine and anterior ethmoidal nerve blocks. This will anesthetize the nasal cavity as well as the roof of mouth, the soft palate and tonsils. So, all these things will be anesthetized with these two important nerve blocks, sphenopalatine and anterior ethmoidal nerve block. Okay, if a patient has a prominent cough reflex, two very important nerve blocks can be practiced in combination, superior laryngeal nerve block and transtracheal block. So we can go for transtracheal block with superior laryngeal nerve block. Now together, these combination of these two, superior laryngeal and transtracheal, would anesthetize the entire respiratory tract. Above vocal cord, superior laryngeal nerve would anesthetize, and below vocal cord, that the transtracheal nerve would anesthetize. The transtracheal approach would anesthetize. Now, here the next question would be that tell us the innervation of the airway. So, entire innervation of the airway can be asked. So, what are the important nerves? So, you're blocking these nerves. So, what important nerves innervate the airway?